MOHAMMAD GHOREISHI. Please explain us the application of the MS-39 for postoperative evaluation of the ICL.
So I am the last speaker and the time is short, so I will try to make my presentation as short as possible. Fortunately, other speakers made my life easy and mentioned many important things. Which one is proceed with this way or the?
This one. This one.
Okay. I am Dr. GHOREISHI from Iran, and I would like to thank CSO for invitation. As was mentioned previously, all the parameters we have on MS-39, so I will skip the slides because was mentioned before, but the important point is that for ICL, we have to take 16 millimeters wide. We can also take 10 millimeters. It has higher resolution for topography, but for ICL, we need 16 millimeter. And we will have with 16 millimeter all these maps. We have section map, we have, okay. And the machine can determine the parameters automatically, or we can make them manually. So many of the parameters can be measured on the map, on the section, like ACD, weld, thickness, angle to angle, but as was mentioned, be cautious and do not measure the clear lens rise on the map. You can use instead, okay. So this is auto detection. So the machine detects most of the parameters, but some of the parameters we have to measure manually. And crystalline lens is measured from, with this machine, I think this is measured from scalar sphere to scalar sphere, or maybe angle to angle to angle from a sphere. Okay. And as I mentioned, you can measure all the parameters, most of the parameters manually, like corneal ICL vault, anterior chamber depth, corneal thickness. And this is ICL with good valve. This is a ICL. Okay. Do not use this mode for, as I mentioned before, for the crystalline lens rise. Instead, you can use this map, the anterior segment model for measuring the crystalline lens rise, and this is okay. And this is a case, you know, crystalline lens rise is high, but the anterior chamber depth is normal. Just I am asking from the panel, do you use ICL in this case? If the crystalline lens is rising good and the anterior chamber depth is good. So for me, this is a contradiction, but some people take into account the crystalline lens rise. But if you look at the iris pattern, because it is concave, so maybe this case will develop pigment dispersion if you put ICL. So for me, this is contradiction. And for the white measurements, as I have mentioned, that use the adjusted white instead of the usual white. And you can verify visually the white if you look at it. How can I use the pointer? Okay. You have to look at the white, so verify visually. And let's go ahead. And for the adjusting white, you have to go to the settings and choose the adjusted white to white. And I would like Francesco to mention what's the difference between adjusted and adjusted, and how do you adjust based on what parameters do you adjust, what factors. So post-operatively, we can measure all the values that was mentioned before. So this is very normal ICL vault here. This is, yes, this is a high volt here, and this is very low volt. And you can also measure for artiflex edge to corneal distance. This is a very important factor for evaluating the artiflex lens. For AC depths, automatic method measures significantly lower value than manual measurement in post-ICL cases. So be careful if you want to measure anterior chamber depths for post-ICL cases, especially We have the IOL calculation on the MS-39. In post-articulate cases, the difference is much less, but still significant. It is highly recommended to use manual measurement in phakic IOL cases unless CSO has a solution for that. So here, if you look at the anterior chamber, yes, because the automatic measurement measured 2.39. This is anterior chamber depth, and the actual anterior chamber depth is 3 point something else. And this is the false pseudo angle, pseudo anterior chamber depth, because the machine thought that this is the anterior part of the lens, so measure this one. So it doesn't measure correctly. You have to fix that. And this is the, yes, the actual angle, the real angle, the real anterior chamber depth. So these are just, I mentioned some clinical points, and this is also another case. The automatic measurement was 2.2, but the actual measurement is 3.2. So you have to do manually in these cases if you want to measure anterior chamber. Doesn't? Okay. So I did a study and measured the anterior chamber depth in 86 patients with ICL, and this is the automatic measurement. The mean is 2.6, but the manual measurement is 3.17. But with Artiflex, this was not too much difference, but still there is significant difference. So in both cases, you have to do manually. So postoperative evaluation, I call my ICL cases after, the long follow-up for 10 years, mean follow-up 6 years, and measure all parameters. And there were mean follow-up, okay. There were significant changes in most values over time, especially anterior chamber depths. Let me go back here. Anterior chamber decreased an average of 26 millimeter per year. This should be considered for IOL, fake IOL implantation, because we consider 3 millimeter anterior chamber depth. For some people put ICL 2.8 millimeter. We have to predict the anterior chamber depth for a long time. 20 years later or 30 years later, what will happen to the eyes? So our measurement showed that 26 millimeter micrometer is decreased per year in anterior chamber. So if the patient is young, that's an issue, but old is not much issue. And there is no difference between ICL and Artiflex implanted eyes. And with we can use MS-39 for toric assisted. Actually, with MS-39, we have to integrate with a barometry device, but I hope that in future, CSO can develop MS-39 just only to measure the alignment. And this is for tear measurement. So managing high volt was already discussed. Observation and follow-up is not too high or too low. Rotation vertical is another option. And maybe the best solution is ICL exchange. But I have another solution that actually this is not ICL meeting. If it was ICL meeting, I am sure that ICL didn't like this because I didn't exchange. I don't know if they exchange with charge or not in Europe, because for us, they exchange the ICL with charge. Do they exchange without charge? No, I mean the company does charge when you want to exchange or not?
No, they provide us with a new one.
The new one, they charge?
No, they don't charge.
No charge.
Maybe for us it's charged, but for us at that time, we have to wait a long time, very long time. So I came to a solution, and this when the pupil is dilated, also we have to manage. This is a case with a very high volt. Based on OCOS, it was 13.7 millimeter, and the volt was very high and asymmetric. So my solution is a little bit different. I don't know this will work. This video. Can this video run? This video?
Can you start a video?
Okay, is start. So my solution is something that I still doesn't like because they charge me for I think for the new lens maybe, or I have to wait. So I shorten the optics of the lens for the solution. It works. I did in 15 cases so far, and some of them have 5 years follow-up, more than 5 years. Yes, I did. First case, I had significant cell loss, but in the other cases, it is based on your experience. I still exchange also will have the same amount of loss. Oh, I studied. I did cell count in every patient. And the first case, I had more cell loss, but with experience. I don't recommend to the other people, but in the other cases, yes, I didn't have any much cell loss. So you have to be very, very, very careful for this operation. For me, because my patient have to wait a long time, but this isn't the question. And in this case, in the first I had very high vault. So in the second case also I shorten outside the eye. This is safer than, So I amputated 4 optics, 4, and still the vault is very good, I didn't have any low vault here. And this patient ended up with very good postoperative results. And one of them now I have 7 years follow-up with no cell loss, no significant cell loss. And this is the one case before operation and another after the operation. This is hyperopic, and as you see here, the angle is close here, almost close. And after the operation, at least the angle is open here, and the low. Well, okay. Thank you very much.